Howdy. Howdy. That's better. Thank you. Welcome to the Architecture for Health lecture series, which is in collaboration with the School of Public Health. And I'm delighted to introduce Dr. Bita Kash from the School of Public Health. Bita is the Center Director of the National Science Foundation Center for Health Organization Transformation. It's known as CHOT, C-H-O-T. And she's also the Director of the Center for Outcomes Research at Methodist Hospital in Houston. And I know you go back and forth doing that. And we're delighted to have you. She's an associate professor at the School of Public Health, and she received her PhD from Texas A&M University in 2007 in health services research. She currently teaches healthcare strategic planning and marketing for Master of Healthcare Administration and Master of Public Health programs. The MHA capstone course serves on multiple PhD student committees. She's the director of a 6-university National Science Foundation, NSF, Industry University Cooperative Research Center, and with CHOT, and that is anchored at Texas A&M University. She's got a number of credentials after her name and publications and research, and most recently, in the last few years, we've been privileged to have her collaborate on this lecture series between the College of Architecture and the School of Public Health. So I think if I've missed anything, please include it.
This is perfect.
And we're glad to have you, and let's give her a hand.
Thank you. Thank you. Thank you, Professor Mann, for the great introduction. It's delightful to be here. It's an honor to be here with the College of Architecture students and collaborators. And we were just talking with the students right before we got started about how a multidisciplinary approach to any solution is not only necessary, it's required today. And so that's one of my passions, to make it as painful as possible and bring in many collaborators in order to come up with greatest innovations in healthcare, and really pays off. And this is, today's presentation is an example of working not only an academic side, an academic researcher working with industry, but also many different disciplines coming together. So this project shows you how we looked at understanding future models of cancer care, since things are changing rapidly in the way we provide care for cancer patients, and the population of cancer patients are changing. And we worked with HKS, which is a leading multinational architecture firm, and some students from departments that are from various colleges. So we have Arsalan was from College of Architecture. We had Molly, who is a master's in healthcare administration student, already graduated with a job. We had Megan, who was at HKS, the architecture firm, Sarah, who was a student in industrial systems engineering, and Abigail, who was a business major. So you can see the many different disciplines coming together for us to come up with the implications of these new models for the healthcare industry, specifically to space and design. So I'll walk you through a little bit about the background of what's going on with cancer and our cancer populations today. And we usually start with some demographics and some incidence rates. So we know that in America, we have about 15.5 million people with a history of cancer. We have 1.6 million new cancer cases every year, so we're doing a great job diagnosing cancer, and 600,000 deaths. So it makes cancer the second most common reason for death in the United States, and many people don't realize that. The other shocking fact is that it affects men. So we hear a lot about breast cancer awareness and so on. So when you look at lifetime risk for developing cancer, 42% of men are affected. And about 90%, so 86% of diagnoses are in people aged 50 and older. So we're talking about an older population that is diagnosed with cancer very effectively, and we're much more effective today keeping this population diagnosed with cancer alive. So we're doing much better with diagnosis. So diagnostic tests, not only tests have increased, but we're doing a better job in early diagnosis. So overall incidence has decreased, and then mortality has decreased. So the combination of all these conditions are resulting in both more cases as well as more attention given to survivorship in making the quality of life of people diagnosed with cancer who've survived the treatment better. Taking a look then at the process of care across what we call the care continuum, what happens. What you can see, often we use the process of care and the care continuum to look at where things break down. And you will see at the bottom here, transition of care. Often, most errors and when things break down have to do with transitions of care. And look at how many siloed activities, centers, or places you might go to in order to get different types of care. So first you have risk assessment. So often that's done with your family practitioner, family doctor, or you might be doing risk assessments more and more at home now as well with tests that you can get through the website and the mail and send back in. You have detection, so better screenings, appropriate testing. Then you move to diagnosis, where often imaging, labs, biopsies come in. And then you move on to treatment that often might require surgery, chemotherapy, radiation. And then after that treatment, everything goes well, you're moving to post-treatment survivorship. And then sometimes you also are dealing with end-of-life care where palliative care becomes important. All these aspects of care, what we're interested in is making sure that the process of care is well done and there's less breakdowns and errors. And then what we're interested in is patient outcomes. And more today, patient outcomes are not just, okay, you're free of cancer and you survived, but it's also the patient experience. So when the patient experience becomes important, even as part of payment, I think architecture and design very much becomes very relevant more than ever as well. So in starting with this, it's also important to see what the experts in this field say about this. So the American Society of Clinical Oncologists have a framework for organizing cancer care, and this is a recent report, 2016. And when you look at their areas of importance, so that they have these 7 goals that they share with us, it's also quite relevant to design, engineering, and understanding the care process. So what they find important is to engage patients in their care early, qualified staff, trained and coordinated workforce, a workforce that talks to each other, research to develop new therapies, which we are doing a great job at today, and learning healthcare information technology. So this is where we're talking about decision support systems, electronic medical records that are empowered by those clinical pathways, decision support systems for providers, and also those systems that learn as we practice, as the best specialists are practicing and providing care. And then translation of evidence into practice, which today takes a long time, and we're always hoping and trying and to make that translation faster. Accessible, equitable and affordable cancer care. In America, that is our probably biggest challenge. We do have the best cancer care you can get in all of the world, but it's not affordable or accessible to all Americans. So it is a biggest challenge, I believe, for the nation. And then also high-value cancer care, which means how do we define value? So we talked about a bit, it's not just about surviving, but also some things to do with your quality of life. So let me tell you about the project purpose. I will not bore you too much with the methods approach, but basically what we tried to do is really understand the current knowledge and the emerging models of care for cancer by reviewing what it is people are doing and what works, what's evidence-based, and then be able to translate that to implications for engineering and designing the new facilities for cancer care in the future. So the systematic review went this way. We thought about 1,500 articles were very relevant, and all those students you saw at the beginning had to read them and figure out what to do with them, because you need at least 3 people reading and triangulating the results and coding them. So at the end, what we realized in reading through all the evidence and studies, that really only 20 studies were most important, most relevant for us to focus on. And from those, I'm presenting to you about 3-4 models to be aware of, models of care that we need to be aware of. Before we start, and this is a whole chapter in that report, is no matter what model is emerging and how great our research is and how wonderful we organize as a care team and want to do things better for the patient, everything depends on the payment system that is put in place, which is a regulatory external factor, right? So pretty much no matter how great we know multidisciplinary care is good, coordinating across silos and across clinics and hospital and clinic is a great thing, depending on what the payment model tells you to do or what makes sense, you will practice that way. So you see today that payment models are moving towards less siloed patients for each encounter to each provider. We are moving much more towards a concept called pay for performance, meaning at the end, how did your team as a whole perform? Did the patient survive, do well, not get readmitted, no reoccurrence of cancer, therefore we can pay you for the performance of that team. And then the other main trend in payment is bundled payments, where everybody takes risk together. So basically a payment agency, which is usually from a government standpoint, Medicaid or Medicare, and Medicare is getting very much invested in that with that 4.7 specialty-based global payment, where Medicare will tell you, we want you to take care of our population of patients, and we'll give you one bundled payment. Now, oncologist, radiologist, family medicine doctor, hospital, surgeon, you guys figure out how you would like to unbundle that payment at the end. Does that make sense? So keeping in mind that our payment models really do drive the way we practice and take care of our patients. One area that we looked at in terms of research, the way National Institute of NCI, National Cancer Institute, has organized their research is also very important. So sometimes, as I was sharing with you at the beginning of the class, this connection of research and practice is an important one. We can learn from each other. And so the way NCI has organized to improve the population of cancer patients who are included in clinical trials is by developing a hub and spokes model, basically. So what they have is, this is the National Community Oncology Research Program, or NCORP. And the components they have are community sites, So they have research bases that are usually at big academic medical centers, universities. They have community sites. They have specifically targeted minority underserved community sites that are in green. And then they have the component, subcomponent sites that are coordinating. So if you take a look at one example, and you can go on their website and look at many different examples. If you look at one example here, you see how great you can expand your reach, especially with this one, they're interested to increase the diversity in the study population, right? So imagine if you're signing up people in a clinical trial and all of them show up at MD Anderson in Houston, what type of patients will you have? What type of population of patients will you have? Very homogeneous. People with insurance and people who could make it there. So what this does is for your research study, you need a diverse population. So really understanding one type of population and how to make them better and develop treatments is not as impactful than really understanding how we do that for a diverse population. And this is an example where research is trying to do that, and I think it's a good one to translate into practice as well. So here's officially the emerging models of care that we would like to share with our readership and audience. And the first one is called the Rapid Learning Cancer Care Model. Rapid Learning Cancer Care Model has leveraged technology such that research, translation of findings, and then learning of the system into incorporating that into your care model happens rapidly, right? So we're able to do that rapidly, and there is a few examples in the nation that are doing this. I'm not saying they're perfect, but we are getting there. So what happens is, as you're generating the best evidence relevant to each individual patient, so it's evidence-based population care with an individualized approach where it's very patient-centered at the same time. So you have standard care processes, but as you're generating evidence, you're adjusting them for one specific patient. Your decision support system learns as you're practicing and incorporating research findings. And so it will suggest to you how to care for your next patient best. So you enhance the quality of care, you enhance patient safety, and hopefully at the end, healthcare value. Not saying it's not expensive to do this. That's a quite expensive setup, but long-term, this should improve value since you're using the most relevant, most effective therapies on specific patients. So that's the Rapid Learning Cancer Care Model. The other one that we thought we needed to highlight in emerging models of care, it's called the Integrated Practice Unit Model. It is very similar to what you have seen happen on the primary care side. Anybody heard or part of, is your doctor maybe part of a patient-centered medical home? Or do you know anything about that? Anyone? Well, I would encourage you to learn about it. So the patient-centered medical home has become a model of interdisciplinary care and comprehensive care that addresses various needs of the patient, even if they're not medical. So if it's social needs, and one big component of it is behavioral health. So it's connecting them with the right social resources, understanding behavioral health, and so often you also have co-location with other specialties that are important, and you're doing a better job. You're looking, let's say you're going to your family medicine doctor, and you realize the family medicine practice realizes 60% of my patients are dealing with diabetes. So they put a program around diabetes, include a nutritionist, include exercise specialists, include behavioral health, coaching, in order to do a better job managing that population. So what we have seen is in cancer care, we have moved to, cancer care has become a chronic disease, right? We're doing a better job keeping us alive. So therefore, we're much more like a diabetic patient than we are the traditional cancer patient. So it makes sense to really mimic that same model. So when you look at the integrated practice unit, it looks at 3 tiers of targets and performance. The same as with the patient-centered medical homes, it's very much target measure oriented. And so what you look at, that first tier, we're interested in survival and degree of recovery, health and recovery. So that's tier 1. In tier 2, we're interested in the process of recovery. Time it takes you to go back to normal activities, time where you're looking more like yourself again. And then in tier 3, there's measures related to sustainability. And so, for example, taking that integrated practice unit model to cancer care, you can get an idea of what is it specifically that I'm talking about. So in tier 1, the measure is cancer reoccurrence. It didn't come back, we did a great job. In tier 2, we're looking at achievement of functional and cosmetic status. No nausea, vomiting, we have good pain management, so that's tier 2 process of care type measures and what we're interested to achieve. And then in tier 3, what we're looking at is a much longer survivor rate as a basic measure, remission, functional status, breast preservation, and conservative surgery outcomes. So that gives you an idea of more of an integrated approach. And next, I'm going to tell you a little bit about clinical systems, with a little background about clinical systems and how they have been evolving as well and where we're going with that. So when you look at clinical systems, often the way we look at them is system theory. Anybody interested in systems theory? Any engineers in here wanting to do that? So systems theory really is a good theory to apply to clinical systems too, because it shows us that we're mostly working in these microsystems. We're working in these microclinical systems. The microclinical system means in radiology, it's the radiology tech, nurse, biopsy tech, radiologist, right, and the people who run the machines. That's the microclinical system. In oncology, it's the oncologist, the chemotherapy suite, and nurses, so that's another microclinical system. In surgery, it's whoever shows up in the OR, and before and after, that's another microsystem. So we're often, what we see working very effectively in these microsystems, and performance in these microsystems are outstanding. The macro system is often interested in telling you how to coordinate, and the macro system also decides on how payment is often nowadays unbundled, right? So you have to deal with the macro system, and often macro systems become involved in coordinating that care. And you'll see in a minute that it's probably not ideal for the macro system. So, but what is a macro system when we're talking macro system? A hospital system, right? The big system. So it's all of Houston Methodist and all of its 7 hospitals. And then what we have is this concept of a mesosystem. In a mesosystem, usually, ideally, different representatives from the microsystems, these clinical teams, come together to coordinate. So in terms of performance being measured in these clinical microsystems, as I told you, they do really well. So performance is usually measured in terms of quality safety, and we do a great job measuring that. In terms of patient outcomes, we do that for each clinical microsystem. And then we also look at professional development, making sure that there is joy and pride and satisfaction in our healthcare workers. So that's very, very well done, and it's part of continuous quality improvement. But when we try to get into this emerging new model of care that is fully coordinated, microsystems fall into this orange category. They're fragmented. They might be great. Every one of those bubbles is great by itself. We're doing a great job measuring the outcomes for each one of those microsystems, for radiology, for oncology, for surgery. They're doing a great job, but they're fragmented, as you see in the orange box. What we have moved to when remember the macro system, the health system getting involved? They've done a good job telling us where to go next, so it's become sequential, right? So they know it's now you do this, then you do that. They might even have gatekeepers and say, no, you can't do this before you go see somebody else. So it's become a more sequential care coordination model. And really where we're going, wanting to go, ideally emerging to go as a care model is that fully coordinated cancer care. How do we do this? Let's look at this again, because I know systems theory can be a little bit boring. So this gives you, again, the example of what these microsystems are. Diagnostic care team is a microsystem, right? Micro clinical team. The clinical supportive care team. And then you have the patient survivorship team. So I just took the whole process of care for cancer care and made it into 3 categories of what's happening. The patient in the middle is dealing with these 3. And usually you might even have to go to one of these providers and say, I need my images to take with me to the oncologist because something was not sent over, right? So it's fragmented. So here you have the patient coordinating his or her own care. Here's the sequential care model where you have the macro system, health system, telling you, here is the sequential way of you're going to go through the system, and as a big system, I'm going to oversee all this. Still, the patient is dealing with all this, just being told where to go next, right? And then here ultimately is where we're moving to, which is the fully coordinated cancer care system, where each one of these groups, diagnostic, clinical support team, treatment team, patient survivorship, has representatives in this big bubble, blue bubble, of a team of teams coordinating care and talking about the patient. So that's ideally where we're evolving to. Does that make sense now? All right, so looking at all these emerging, all this information we get from the latest knowledge on where care is going for cancer, then we then decided, okay, we should have a vision and future for this dream team characteristics. It looks like cancer care has become very much team-based. So what's this dream team characteristics? So it's very much aligned with what the American Clinical Oncology Society was telling us, if you remember that slide. A well-trained support staff that can take on a lot of responsibility. So our support staff needs to really step up and get better trained to take on more responsibility in coordinating, documenting, contacting patients. A good communication, I would say a great communication system that allows both formal and informal exchange of information. We have seen a lot, not just in our research and literature, but hands-on anecdotal evidence from clinicians that we cannot depend on the electronic medical record, no matter how integrated and great it is, to communicate relevant, important, urgent information about patients to other providers. The most effective way to communicate still, to coordinate care and do a good job for your patient is, guess what? What works the best? What is that? Face-to-face is hard, but that would be nice. Call, exactly. It's for a radiologist to call up the oncologist and say, hey, I'm a little concerned about these images. You might want to pay extra attention to this. Or call up the family medicine doctor and say, I need to see that patient again soon. So it is still the phone call. And so, yeah, it's kind of an ancient technology, but it seems to work really well. So there needs to be good communication, both formal, informal, with different levels of technology. And when we need it, when I need to look up information about the patient, yes, the EHR should work. I should be able to access information on patients when needed quickly. So that's one thing. And then big importance placed on palliative team. So really caring for cancer patients today and in the future without a solid palliative team and a space for that type of care is very important. So we need to think about palliative care and how we design the space around that. So all of this ended up in a nice publication in the Journal of Integrative Oncology, which we recently published, and a few conferences. Mostly our conferences have been at architecture conferences, so our work is quite valued, and looks like Dr. Upali Ananda has been at several conferences presenting this work. And so finally, what we like to kind of give a message to our future architects, designers, in working with us healthcare practitioners and researchers and hospitals and administrators, keep in mind that no matter what it is, and we talked about cancer care, your care continuum that we started out with, so the cancer continuum, when we move from prevention to risk assessment to diagnosis, detection, treatment, survivorship, and then end-of-life planning or palliative care, should be fully aligned with your facility design continuum. So don't just focus on facility design means I'm going to build you the best design and spaces for treatment, or I'm focused on the best spaces for detection and diagnostic and lab. Really what you need to keep in mind is what we now need to keep in mind based on our payment models and where we're going in healthcare is the whole continuum, because that's how we're expected to provide care, and that's how we're going to be paid to provide care, is the whole continuum and the final result. So keep that in mind when you're designing places. Another thing to keep in mind, I think it's important for you to know, you remember I stressed the importance of the mesosystem level team of teams coming together to coordinate? And somebody said the most effective care coordination communication mode should be face-to-face, right? So put those together. Is it really possible, feasible, sustainable to do that? So technology can help. So yes, we need to come together as a team of teams, representatives from oncology, radiology, surgeons, the social worker, the family practice doctor that knows you the best, and the researchers at the table to discuss each patient, to really spend at least 10 to 30 minutes sometimes on each patient to not only stage the patient for cancer treatment, to also decide what is the best treatment for this patient. And usually that happens in a tumor conference, right, which is face-to-face. And it's very hard to get everybody together into a conference room to talk and present each patient case in order to come up with that treatment plan. We're not getting, and you might not be aware that not every hospital or community has a tumor conference. So we're in Bryan College Station, which is, I wouldn't call Bryan College Station rural. We have how many hospitals? At least 5 hospitals, maybe? Am I wrong? 4 hospitals? 5 hospitals? Quite a bit for the size of the community. And only one of these hospitals has a tumor board, a tumor conference that meets and discusses patients. So many times patients are not aware of this. So in order to make this type of care, availability to this type of discussion on each case possible for more patients, bigger populations, it might need to happen as a virtual conference, connecting with experts at a hub and being able to have a teleconference where you have access to the images and access to experts to advise you and access to local services and social services to understand what's best for that patient. So when you're talking about care that is happening and moving towards virtual, again, it's important to imagine what kind of spaces you need to provide at those hubs versus those community hospitals to make this happen. And then finally, we talked about how the facility design continuum needs to be aligned with the cancer care continuum. Here is a model where we're used to, as health services researchers, to incorporate, and this model here at the end, remember the first slide where on the right-hand side, we were measuring outcomes, patient mortality, reoccurrence, quality of life, patient experience. So we're measuring the experience throughout the continuum. We as health services researchers have been very involved in understanding the social environment and the effect of the social environment on this care continuum processes and then outcomes. So now more than ever, and I would say for the past over 50 years, we've been interested in differences in race, ethnicity, health literacy, social capital, education, resources, insurance type, and we know and we have identified the effect size, significant effect of education, literacy, income, household income, and so on those health outcomes and how it affects the care continuum. Guess what your job is? To do the rest. That bottom part, the green part, is still something that we are wondering about. So when you're moving towards truly evidence-based design, what you're doing is you're understanding how the built environment is affecting outcomes in this cancer care continuum. Built environment meaning things having to do with land use, zoning, public resources, transportation, food environment, spaces, walkability, access, mixed use spaces. How are those things affecting patient outcomes, patient experiences, and the whole care continuum? So really focusing on that built environment is something that we're also doing in multidisciplinary teams, for example, with collaborating with Dr. Liu and Dr. Hamilton in understanding a research design that will allow us to get a better understanding of this. Doing okay with time? 5 minutes, okay, we're wrapping up. All right, so implications for facility design. What we learned, this is just a summary of 5 things you need to know before you design a cancer center. 5 things we talked about. Hub and spokes, right? Hub and spokes models and regional plans of care. So remember NCORPs and our discussion around how we need virtual tumor boards coming together. Hub and spokes models. Data integrated collaboration, making sure that data is available, accessible at different ports, different places when we need them. Team of team workplace, right? We're taking an approach where we're doing care coordination with the team of team model. Co-location of modalities, specialties for that continuum of care. Remember the integrated practice model that we identified? looks like we need more than just diagnostics, oncology, surgery, and end-of-life planning. We need many different team members, specialties coming together. And we can't have them all at the same place at all times. So think about flexibility at the end as well. So here's some quick examples of how people have looked at this in terms of this is looking at a hub and spokes model for design, and it's based out of the Mayo Clinic. And I'll be a little bit faster here. We can then open it up for questions at the end. And then the flexibility of design, I'm sure you guys can read these things better than I can do, but you see spaces that can be dedicated to freestanding ED and can be quickly transformed to ambulatory care, so flexibility in design. And then the whole concept of modular design that will usually helps out with co-location, where you have maybe a specialist coming for 2 days a week to a clinic versus another specialist for another 2 days, and they have different needs or space needs. So at the end, it's all about healing, and we'll end with a few pictures of what else really counts in the process of healing. There is randomized clinical trials telling us that mindfulness will improve your outcomes. So spirituality, mindfulness is something that we keep in mind in design as well. Spaces for patients where families, that accommodates families, social interaction is proven to help your outcomes as well. Light and nature, something that we're studying actually currently at Houston Methodist, the effect of nature on health outcomes and healing, something to keep in mind. So many things to keep in mind when you're designing your future cancer hospital or cancer center. Thank you so much for having me today, and this concludes the lecture.
Dr. Kash, thank you so much. Wonderful presentation. We've got time for a few questions from the audience. Yes? If you come to the microphone, please.
Hi, I'm Brooke Hendricks. I'm a first-year Masters of Architecture student. And I know we talk a lot about the design differences between adult cancer centers and children cancer centers. And so I was wondering if you could talk a little bit about that with your research process, how it would change or modify for a children cancer center, or would it stay the same?
Very good. That's a great question. Thank you, Brooke. So in our approach to our research, we included both populations for pediatric and adult. So specific to this project, I can't tell you that we extracted differences there. We have worked closely with children's hospitals, and obviously the need of that patient population is very much different. So the first thing I would say about children's hospital is that it needs to be parent-centric. So we talk a lot about making the babies and the kids happy and comfortable, and I believe the best source of information on how to do that and really the patient experience is actually the parent experience. So I think that would be my first advice to you, is to make it parent-centric. And with cancer, I mean, you're dealing with usually with children's pediatric cancer facilities. You're in one of the most inspiring places that you can be in, when especially looking at interacting with the healthcare workers and the physicians. It's just one of those, if you haven't interacted in one or been to one, I would suggest it, because once you're in a children's hospitals or in the oncology department, you'll say, I never want to work for or in something other than this. Because it is one of those unique, utopian, just care-oriented, caring, kind, compassionate places to work in. So I get a lot of inspiration from people who work there. So I would in designing places like that also talk a lot to people who work there, to the healthcare workers in that field. Another question?
No questions. Yes,
Yes.
please.
Hi, my name is Hao. I'm second year Master of Architecture student. You mentioned facility design continuum is a whole continuum. And I also think the patient-centered medical home is a great idea. And do you think about the staff in the future cancer hospital? What's the design consideration for the staff?
Yes, thank you. Great question. Design considerations for the staff are very important. The staff, so we're right now in the U.S., and it's just not just U.S., many Western countries, including UK, suffering from a epidemic of physician and nurse burnout. And if you can help with that in designing places where it improves wellness and resiliency for our workforce, that would be a great contribution, because we have studied it and we know what's wrong with the system. So the reason we're getting physician burnout and less physicians wanting to practice longer, so we have physicians retiring sooner, going into other type of professions, and the worst thing that's happening is we have MDs graduating from medical school and deciding, no, this is not for me. So not everybody graduating from medical school or finishing residency is actually practicing. And we have people who are now getting employed instead of opening their own independent practice. Independent practices work more than full-time, see huge volumes of patients, therefore increase access to care. Staffed physicians that we employ see less patients, right? So we have a major access issue. And with physician burnout, what we have learned is the advancement of technology and how we care for patients with the electronic medical record has helped access to information, billing, improving processes, and developing standardized care plans, but it's really a huge administrative burden on the physicians. So what we have done is we've made the physician who is highly trained and can be taking care of patients and true need, also a billing clerk, right? So that the EMR is not helping them. We know that. Administrative burden is great. Workload is too much, right? And then often there is a value conflict between the health organization, the hospital health system they work with, and the physician. So those values are not well aligned. So they're frustrated. So if you can help with designs that can do a better job improving the wellness of healthcare workers, that's something that I would love to charge you with.
Howdy, my name is Margaret Reagan, and I liked the slide you had a few slides back where cancer patients can sit and do their chemo treatments, I believe. Is
right.
that what that slide was? And have view of nature? And this slide has a beautiful view of nature. But what things can you do to help the person respond as there is nature whenever you're in a highly urban or in a climate where you can't have beautiful green outside all year long?
Very good question. So what can we do when we're in an extremely urban environment, and when we make these windows, there is other buildings, right? Not green space. So there's been recent studies on effect of nature on reducing stress, and they tested the actual real plants versus virtual, so pictures, slides, or posters. And there's not a significant difference in effect. So you could use virtual. So I think I would very much encourage you to use virtual reality, virtual nature images in your design.
Thank you.
They're as effective.